Thank you. Thank you, Phyllis. It's a joy to be with all of you today and to be on this wonderful, innovative webinar in that is the first that is concentrated solely on adult day program and how we can work together across the networks and especially organizations like OPICA that provide to the general community dementia capable care and want to share that resource and expertise with the IDD community as well. It is my joy and pleasure to be able to introduce Dr. Lucille Ezralu, who has been a longtime friend and collaborator, but I could never remember all of her accomplishments. So thank you for sending your bio along, Lucy. She received her PhD in psychology from the Graduate School of Arts and Sciences in Columbia University in 1999. She is a licensed psychologist in New Jersey and in California. She is a certified clinical neuropsychologist, a certified dementia practitioner, and a certified clinician from the National Association for the Duly Diagnosed. She serves on the board of the National Task Group for Intellectual Disabilities and Dementia Practices, and she spearheaded the development of the NTG EDSD. She co-facilitates the NTG Advisory Body and the NTG Applied Research and Clinical Health Arch Committee. Dr. Ezralu is also a member of the advisory board for the ARC of New Jersey's Mainstreaming Medical Care Program. She co-authored with Donna Cavino the Family Crisis Handbook, the updated Family Crisis Handbook, and the enhanced Family Crisis Handbook, a behavioral health, wellness, and toolkit. She is a clinician and educator and consultant, currently serves as senior psychologist, supervisor, and clinical lead of the clinical service branch with the Office of Statewide Clinical Services for California's Department of Developmental Services. She spent 20 years at Trinitas Regional Medical Center in New Jersey, where she served there as clinical administrator as well. She has spent her life and career helping serve those, especially families in need of caregiving resources and staff who serve individuals. It's my pleasure today to welcome her to share her expertise with all of you. Thank you, Lucy.
Thank you so much. I'm so excited to be with you. So if you all will be patient with me, I'm going to try to pull up my presentation for today. And let's see if we can get this to the very beginning. And okay. All right. Okay. From the beginning. Can you all see it?
Mm-hmm. Yes, we can. Thank you.
Good. Thank you so much. Sometimes technology works. Hello. Yay. So I am pleased to talk to you today about IDD and dementia awareness as it might relate to day services staff. So a medical disclaimer, of course, anything that is brought up today is not in lieu of medical advisement. It is basically for educational purposes only. So what are some of the objectives that I have for you within the next hour? Well, I'm hoping with you to overview different types of intellectual and developmental disability, the population of individuals who are considered as having an intellectual and developmental disability is a very diverse population. It's heterogeneous. There are many, many conditions, but we're just going to lift up and talk about a few of the most likely conditions that you're going to encounter in your work through day services. We're going to identify support needs of persons with IDD in the adult daycare setting and introduce the National Task Group Early Detection Screen for Dementia, for early detection of dementia, the EDSD, as a tool that you could use in day services to track any changes that you may observe if you have an individual with IDD who you're supporting and you happen to notice is changing in their behavior or their skill set. So a little bit about how intellectual disability is viewed. Intellectual functioning is a person's way of being able to reason, problem solve, plan, think abstractly, judge options, and learn from their experience. And what we do is we measure a person's IQ with standard IQ tests like the Wechsler, the Stanford-Binet. And but it's important to know that we've moved away from thinking about intellectual disability as only a person's IQ score, but are also very much interested, and we're moving more towards the idea of what is the person's adaptive skill set. And in thinking about that, it probably will occur to you that day programming can have a lot to do with working with individuals around their adaptive skills. So deficits in intellectual functioning and adaptive functioning can affect the person's ability to live independently or meet what we consider age-appropriate expectations for social responsibility. These challenges to adaptive functioning may affect a person's ability to do such things as understand rules, perform tasks of daily living, and participate in family, school, and community activities. So here you see a chart, and I believe I got this chart through the IDD, and you'll see various columns. Where I want to pull your attention is to this column DSM-5 criteria. And note that the vast majority of people who we know to be intellectually disabled actually fall within the mild range of intellectual disability. So it's about 2 standard deviations, which may or may not mean anything to you, from what is considered kind of typical IQ or average IQ. Usually 100 is considered a measured IQ, which is for typically developing individuals as average. So 2 standard deviations would put somebody around a full-scale IQ of 70 or just under that. So people with an IQ within the mild range can live independently with minimal levels of support. And particularly during times of transition or uncertainty, they may be more likely to need supports. Individuals who are in the moderate range of intellectual disability, and they constitute the second most frequently occurring type of intellectual disability, that constitutes about 10% of those whom we know have intellectual or developmental disability. So the person may be able to live independently with moderate levels of support, such as those typically available in congregate settings like group homes. But limited support is needed in daily situations. They're still fairly independent with regards to that. As we get into lower range, severe and profound, you'll see that the percentages drop of the number of people who meet that criteria. And the lower you go on the scale, the more is required in terms of daily assistance with self-care activities and safety supervision. So if you're in the severely intellectually disabled range, you're likely to need extensive on a daily basis. And if you are in the profound range of intellectual ability, that means you're probably requiring 24-hour care, and support is needed for every aspect of daily routine. So what are forms of developmental disorder? So there are many types of disability, but when we think about intellectual and developmental disability, we're talking about disorders that occur either at birth, or while the child is still in gestation, or become evident within the developmental period. They are lifelong conditions. They are usually first occurring, and depending on what state you live in, believe it or not, this is determined by states. The cutoff point for the developmental period is either age 18, or in some states it's age 21. And this becomes important if we think about eligibility for disability services in any particular state. An individual who is developmentally disabled is likely to need lifespan supports and the support of a multidisciplinary team with several different professionals offering several different services. So as I said earlier, there are many forms of developmental disability, but in addition to intellectual disability, the kinds of forms you are most likely to encounter are people who are on the autism spectrum, people who have cerebral palsy, individuals with epilepsy, individuals with Down syndrome, individuals with fetal alcohol spectrum disorder. Now we get to this idea of eligibility for DD services. So again, the eligibility is determined by the state in which you reside, okay? You can apply at any age, but you need to establish that the disability occurred within the developmental period. And this is something that is sometimes confusing for people. So you could be 55 and apply for disability services. However, your condition that is the basis of your application had to have occurred before the age of 18 or before the age of 21, depending on the state that you live in, okay? So you need to have the person check, or you check the state's website for their Office of Developmental Services or Developmental Disability Services for information about the rules for application, how to apply, and what services might be available. Now, some of the individuals whom you encounter who might be eligible for services never got them because there was no one who advocated with them for those services. So they may need assistance in completing an application packet. And most states have services and supports for both children and adults, recognizing that individuals with intellectual and developmental disability will need lifespan services in order to achieve independence and optimal functioning. Many of the state offices of DD services utilize the Medicaid and home community-based services waiver to support services in the range of services for people with intellectual and developmental disability. So, what is the value of day programming for individuals with intellectual and developmental disability? Well, it has tremendous value. It allows the person to be part of a structured environment where they can develop essential life skills. It can help them improve their social interaction. It can help them gain independence by participating in activities that cater to their specific needs. It allows them to pursue personally preferred leisure activities, and it fosters a sense of belonging and connection within their community. So there are just tremendous opportunities that are available to individuals who participate in day programs. So now, we want to move into this idea of a connection between intellectual and developmental disability and dementias. And I know my colleague, Catherine Piers, in the first webinar that was offered, gave you some wonderful foundational information having to do with what we know about intellectual disability and dementias. So what I want to point out is we're really still in the process of learning about the increased risk of people with developmental disabilities other than Down syndrome and with other dementias other than Alzheimer's disease. Sorry about no parens on the end of that, pretty open-ended. So we do know a lot about the connection between Down syndrome and Alzheimer's disease. We know that individuals, particularly with Down syndrome past the age of 50, are at a heightened risk to develop Alzheimer's type dementia. However, we don't know about the
Lucy,
yes.
I'm sorry to interrupt, but there's a little bit of audio problems, a little bit slowing down on our side. I'd advise you to go off the video, and that will help your bandwidth locally.
Oh, okay. We'll do that. Let's see what I can. No, you don't have to apologize. Thank you for letting me know about that. Okay, I'm going to
Just
stop
shut up,
my.
yeah.
Okay, yeah. Does that help? Does that,
Yes, so far,
okay.
yes, thank you.
Okay, thank you for letting me know. I wouldn't know otherwise. Okay. So we don't know, for instance, are people with Down syndrome more at risk for other types of dementia other than Alzheimer's type dementia? What about individuals without Down syndrome? We have some suspicion that individuals with autism who are on that autism spectrum with cerebral palsy and epilepsy may have heightened risks, but it may be for dementias other than Alzheimer's disease. As you know from Catherine's presentation, there are other forms of dementia besides Alzheimer's disease. So we're in the process of learning more, and mainly because we're first experiencing a cohort of individuals with intellectual and developmental disability who are living longer. So we're seeing them aging with their intellectual and developmental disability. So one of the things that I'm going to invite you to do is to think about, when you're working with people, how do you capture observations of change when you know the person is changing from the behavior that you knew was characteristic for them? Um, so of course, dementia itself still is primarily diagnosed, depending on the type of dementia, on observation. For neurotypically developing older adults, we have tests that can yield information about changes, particularly decline from age-relevant behaviors and thinking skills, which we know may signal dementia. But there are very few assessments that provide similar information about change pertinent to detecting dementia for individuals with intellectual and developmental disability. Very little consensus about the use of those tests that do exist. Healthcare practitioners depend upon the collateral information from family members and staff who know the individual best and are in the best position to capture those or recognize those changes from baseline functioning. So what changes might you observe? And remember, dementia adds excess disability to those individuals who have lifelong disability on the basis of their developmental disorder. You may observe changes in their productivity at day program. They're just not doing, like if they were involved in crafts or some other activity, they're just not as productive. You may notice changes in their social behavior. Individuals might even do things that they previously would never have done, that would be considered socially inappropriate or difficult in terms of relating to peers. They may change in the proficiency of their language use. Their level of engagement in activities might change, and their ability to learn new tasks might change. And you'll see an overall change in their level of independence. What might you observe in terms of changes in their cognition? Well, with memory changes, you might see that they are less productive at their work or chores or activities. Problems maintaining focused attention. They might be highly distractible. They might have difficulty adapting to change. And part of that is the ability to learn new information, which is not impossible, but it just may be the person is very slow in learning new information. And it makes their adaptation to changes in the environment a little difficult. You may notice difficulty in everyday problem solving, especially social situations where problems might come up. And you may notice that the person's language skills may become impoverished. In other words, somebody who is frequently fairly talkative is now speaking less. They seem to have difficulty retrieving certain words, and they may respond to it just by clamming up and not having conversations with people. So again, what changes might we observe in terms of behavior? Well, we do know people who have dementia, developing dementia, will show increased impulsivity, hoarding, Verbal and physical aggressive behavior might increase, might be increased reactivity to others, and social behavior that does not match the social situation. We say people who are increasingly restless and agitated. So these are among some of the behaviors you may notice among people that you work with. So what changes might we observe in adaptive skills? And again, adaptive skills, we mean activities of daily living, but we also mean changes in instrumental activities of daily living. Those are IADLs. So in terms of ADLs, daily living skills, you may notice an increase in incontinence, balance and gait problems, a problem that is referred to as apraxia, and it affects just how we sequence various behaviors. So people may have difficulty dressing themselves because they forget or they are not in control of the sequence in which they would dress. Like first you kind of take off what you're wearing, or that you put something else on, and how you go about it. It might affect their ability to self-feed, where they just don't seem to know what to do with the utensil or the plate of food in front of them. Apraxia might affect their ability to speak in a kind of sequenced, logical way. And it can affect it can lead to an increased dependence upon assistance from staff or family members if it's at home, or staff if they're in a group residence, for bathing, grooming, and other activities of daily living. By changes in instrumental activities of daily living, we might notice the person has an increased problem handling money. That's if they were capable of handling money to begin with. They may have difficulty maintaining their own space, so their space in their residence or even in the day program or workspace that they may be in may become cluttered. They have a hard time organizing their things. They have a hard time keeping track of their things. They may have difficulty with shopping or cleaning if these were skills that were previously in their repertoire. And they may have difficulty using devices that they've previously used, such as the phone or other devices. What are we interested in tracking? We're interested in tracking changes in adaptive behavior, those behaviors that I mentioned in the previous slide, that are associated with independent functioning, that are associated with quality of life, so that those changes could lead to a diminishment of quality of life and get in the way of the person's valued goals with independent living, work, or relationships, and may put the individual or others at risk in terms of their own safety or in terms of loss of their placement. And we also want to know responses to any of the interventions that we're using to make sure that they are, effective. So those are things we might be wanting to track. So I did mention the term baseline before, and I think it is helpful to pay attention to that term and what is meant by that. By baseline, we mean what is typical, what is usual and characteristic for that person. So that presumes that you know what the person is usually like. And so that would be in terms of their memory, their thinking, their behavior, their ability to participate in activities of daily living. So as an example, let's take David. David usually remembers staff names and he's good about following up on his work routine. He usually can follow two-step instructions, is mild-mannered and polite, and is independent in his ADLs. However, if he cannot learn the names of new staff members and repeatedly refers to them by the names of staff who have long ago left his place of work, if he has difficulty following through on instructions, is frequently irritable and rude, and needs supervision in showering and toileting, we would say that he's displaying a change or departure from what we knew to be his baseline characteristic. So I'm just giving you and actually, I think Catherine Pierce showed this to you in her presentation. It's both the QR code to get onto the NTG site, where you can find the EDSD, the early detection screen for dementia. I'm going to be reviewing that a little bit and inviting you to go on, if you have not seen the form, to go onto our site. You can download the form, or you can look at an electronic version of the form. We also have the EDSD in multiple languages. So you do not have to be a clinician to complete the EDSD. In fact, it was designed to be completed by the people who know the individual best. That would be family members and staff. The NTG EDSD is to be completed by somebody who is familiar with the consumer. This is not a clinical tool. It is an administrative tool. That means that it helps teams make decisions about how to best support somebody. So if the consumer is attending your day program, it may be helpful for the staff of the day program to complete a record form. If the person is living at home, then their family could fill out a form. And if they're living in a group residence, their staff at the residence can fill out a form. And it would be really great to collaborate and just see what are people seeing across settings with regards to how this person is functioning. You do not need the person even there to complete it. What you need is you have to gather medical and chart information to fill out some of the questions pertinent to medical and mental health status and whether there have been changes. So the NTG EDSD utilizes a Likert rating scale. So there are 4 items that represent a range of choices for the same question. Very often you may be familiar with this idea of a Likert scale that asks you, do you agree, somewhat agree, neutral, disagree, strongly disagree? That's a Likert scale. For the early detection screen for dementia, you're asked to indicate on pages 3 and 4 if something that the item in question has always been the case, but is worse, or is a new symptom, or does not apply. So let's consider what each of these tell us about as a way of capturing our observations about change if change is occurring. So let's look at this idea of always been the case. There are a series of questions on pages 3 or 4 where you are asked to rate, has it always been the case? So in terms of bathing, let's take the issue of Keenan. Keenan has always needed help bathing. So it's always been the case. It has always been the case that he does not initiate conversations, and he always sleeps excessive amounts. By choosing the rating always being the case, you're indicating that it's usual for the person and that you really are not observing any particular change in their behavior. If you, however, are choosing always the case but worse for pages 3 and 4, the items on that, what does that mean? It means that there has been a change. The person needs increased help. So Rose, consider Rose for the minute, has previously needed verbal prompts to complete showering. Now she needs hand-over-hand assistance. So that means she's always needed assistance, but now she needs even more assistance in this area. Rose has mobility problems. She has always had mobility problems. She's previously used a walker. Now she needs a wheelchair for anything further than short distances. So that's a change. She's always had mobility issues, but now it's progressed to the point where she needs a wheelchair rather than a walker, at least for short distances. She previously needed her food cut up for her, but now she can only eat finger food. So, she's really not even able to manage a fork if the food has been cut up. She's now just not using utensils, she's using her fingers. By choosing always been the case but worse, you're indicating the person has lost even more skills and is less independent with an activity of daily living for which the person already had a problem. It's because the situation has gotten worse. A new symptom for the items on page 3 and 4. What do we mean by choosing new symptom? Well, that category, we choose new symptom, we mean that we are just becoming aware. We're observing something that we didn't previously observe. So Walt has episodes of incontinence, which began 3 months ago. So if this form was filled out for Walt 4 months ago, we wouldn't have checked this as a new symptom, but as of 3 months ago, it is a new symptom. Walt has become lost while walking home from his program twice within the past 6 months. So this is a relatively new thing that has happened within the past 6 months. He cannot remember the name of his new staff and began calling the new staff by the name of a worker who's not been at his home for several years. So again, this is a change in memory that is relatively new and is therefore a new symptom. You're indicating it wasn't a problem observed during the last assessment, but is a problem now and is a new sign of possible changes. And the category does not apply. What do we mean by that? We mean that it's not a problem. Joy does not need assistance in showering. It does not apply. She does not need assistance in dressing. Does not apply. Joy may have episodes of mild forgetfulness, but this does not interfere with her work or daily activities. By choosing does not apply, we are indicating that this is an area in which Joy does not have a problem. So, referring back to the National Task Group Early Detection Screen for Dementia, again, it is not a diagnostic tool. One would never say that person has Alzheimer's disease or any other form of dementia on the basis of using the tools, even if they had new symptoms all over the place. You still are only capturing your observation of change. It is not meant to be the clinical basis of a diagnosis, but it is helping move things along about where we might have to, what we might have to do next and where we might have to look next. We should first use it with adults with Down syndrome around the age of 40 and individuals who are non-Down syndrome form of intellectual disability around mid-50s. And the reason for that is we know that individuals with Down syndrome are much more likely to exhibit signs of Alzheimer's disease beginning in their 50s. So we want a baseline measure before there is likely changes. So we have something to compare it to. And for individuals with intellectual disability who do not have Down syndrome, right now we don't have any reason to believe that they have heightened susceptibility in their 50s. So it's okay to wait a little bit longer before you get the baseline. Of course, there's no harm in doing the baseline earlier if that works out for your setting. So record suspected behavioral changes and differences that you observe for adults with ID, including setting. And that's a baseline. Track changes and highlight areas that require further examination. Also useful for collective discussion and dementia care planning involving families and care providers. Can aid community practitioners when examining and assessing adults with intellectual disability, and it's designed to be completed by family and staff caregivers at local agencies and organizations. So again, this tool is not for the diagnosis of dementia. It's an administrative rating tool, not a clinical tool. The diagnosis of a neurocognitive disorder of dementia, whether it's Alzheimer's disease multi-infarct dementia, Lewy bodies, frontal lobe dementia, whatever the dementia might be, involves medical exam and direct cognitive and adaptive testing of the individual in question. So this is a very different kind of tool. The consumer is already, if the consumer is already known to have a neurocognitive disorder like Alzheimer's disease, some form of dementia, you can still use the rating form to baseline observations of change, but do not need to continue using it if the person's been formally diagnosed with a neurocognitive disorder like Alzheimer's disease or multi-infarct dementia. So how do we use the ratings from the early detection screen for dementia? Well, we look for patterns. What are areas in which change has been noted? What is the extent of the change that we've observed? Is something being done currently to address these identified issues, or is that something that we need to initiate some action plan in terms of addressing what we've observed? So, of course, whoever is assigned to rate the individual, and again, at the day program setting, it's a good idea to have the person who has the most contact with the individual as the person who would be doing the rating. You're going to share the findings within the members of your team. You're going to discuss observations that were captured by the ratings within your group. And it would be a good idea also to contact the person if they live in the residence or if they are in a family setting. Who else might be able to fill out something so you can all kind of pool your observations about how the person is currently doing across settings and reconcile any discrepancies across settings. So it may be that if John lives at home, his family is not noticing some of the changes that you're noticing in day program because there are no real task demands placed on him at home. So the family members might have a different experience of John than you do at the day program. So it's important to kind of look for those discrepancies and look how to reconcile it. And then request additional information if necessary, brainstorm possible approaches, and then come up with a plan of action. Is it time to refer to the healthcare provider or other professionals to move that person's healthcare assessment down the road? And evaluate any plan that you have developed, evaluate the effectiveness in providing the supports. So as you probably know, is that Alzheimer's disease and other neurocognitive disorders that we refer to as dementia are evolving conditions. So what may be helpful and supportive and work for supports at one period of time may not at another period of time. So the teams really need to be kept abreast of how things are changing and in what direction for the individual. So sharing the findings from the EDSD can help advance healthcare conversations. First of all, it raises dementia, or maybe even a question about other problems for exploration as possible explanations for change. I can remember a recent meeting I was at in which it was pretty clear the person wasn't processing information. And then the question was raised, you know, when's the last time the person had a hearing exam? When's the last time the person had a vision exam? And so being able to investigate those sensory issues, although it may not explain those changes, it might contribute to our understanding what's going on with the person. So there might be competing issues to explore. In addition to dementia, the following can be contributing to observed changes, as I just mentioned: sensory loss or depression, or the person has an unaddressed medical problem which has led to delirium, in which they really have a rapidly changing mental status, or unaddressed pain, or something is going on in their family or home situation that is very stressful and they are responding to. So what are the types of decisions that may follow from the EDSD? Well, the teams may decide that it's time to modify the residence or change the residence or change the staffing support or change the type of program the person is doing. And how do we develop a positive daily routine for the individual, and what activities make the most sense for this individual at this point in time? So there are some things I wanted to lift up as take-home messages. Family and staff are in the best position to recognize everyday changes in a person in terms of their memory, thinking, behavior skills, and activities of daily living, because the people who work and know the person best know what is baseline characteristic for them, and they know when the person is changing from that baseline characteristic. And I don't mean like one day, over a period of time. The EDSD, the early detection screen for dementia that is put out through the National Task Group, is an administrative screening tool that can be used to capture that observation of change. That is valuable information about the functioning of the individual with intellectual and developmental disability. And the findings from that tool can aid and promote healthcare advocacy and the development of relevant services and supports at the day program level. Findings can be shared with the members of an interdisciplinary team. Most individuals with intellectual and developmental disabilities who are linked to services within their state have a team, and also to share information with the person's healthcare provider so that appropriate decisions about services, supports, and treatments can be made. So this is the National Task Group on Intellectual Disabilities and Dementia Practices, and the QR code that leads to our
Lucy, are you still there?
I'm here.
Okay. Was that your last?
Yep, that was my last.
Okay, because I have a question for you, and thank you for an excellent, very nicely presented. Especially, you've been in the field so long, just excellent being able to explain the field to those that may not have been. So the question is from Elizabeth Gould. Is it possible that changes you're observing in a person's ability to manage ADLs can be due to progression of their IDD condition and not dementia? For example, mobility changes.
I see what you're saying. Well, it's not likely that, there's going to be much of a progression in terms of their intellectual and developmental disability per se. However, as they age, there certainly can be other changes that could be explaining the problem. So mobility issues, pain, so arthritis, so it really depends on what would be impacting mobility. But you're very right to kind of identify that dementia is not the reason for all observed change. And so one of the things is to have a healthy degree of skepticism. So if you get a finding that there have been observed changes, the questions begin. It doesn't answer the question. It begins the question. Okay, we're observing this. What might be the possible reasons the person is having mobility changes, or whatever else is going on that you observe? So thank you for that question, because I think it's very much to the point of, we're trying to understand the person comprehensively. And this tool is only meant to get the conversation started. It doesn't end the conversation there.
Yeah, do you mind if I add to as well?
Not at all.
The impact of the lifelong intellectual disability can cause an increase in the symptoms of secondary conditions. For example, with cerebral palsy, someone who's been non-ambulatory, likely she's had muscle reduction in joints impacted by arthritis, as you mentioned. And so it's very, very likely that you're going to see losses as a person gets older, in some of the function that's not a direct result of the intellectual disability, but a result of the secondary conditions that the person is a higher risk for. And again,
Yeah,
the
that's an
example, go
excellent
ahead.
point. Mhm. Yeah, so it made me think as you were speaking that it's really important to know a little bit of the natural history of particularly developmental disability, that because it's such a heterogeneous population. There's so many conditions, very often with high degree of co-occurring medical problems. So, let's say you have somebody with epilepsy. If you have a life full of cumulative stress on the individual of having seizures over time, which can absolutely affect functioning. It's not dementia per se, but it certainly can affect their cognitive and adaptive skills. Or, they're just certain disabilities that are more likely to set the person up for some problems as they age. Um, there's a lot in the literature about Prader-Willi and how there are people who, with Prader-Willi, as they age, they have declining cognition or cognitive status. Um, they're not necessarily calling it dementia, but they do notice there's something about that condition that sets the person up for that kind of aging with disability. So, so very good point. And with cerebral palsy, by the way, I remember when I went to school last century,
Me too.
the thinking was that cerebral palsy is a static event. You have cerebral palsy, there are no changes. There's nothing about that changed. No, au contraire, it absolutely changes as the person ages in terms of their strength, their stamina, their, the mobility issues, etc. So yeah, so those are changes you would observe, and knowing that that can happen with somebody that has a cerebral palsy, and certainly certain forms of cerebral palsy where that is
Yeah, a
more
couple
like.
of points I'd like to add before we have another hand up with Janet. I'll be right to you, Janet. One is, as day program providers, rarely are you responsible for any diagnostic responsibilities or for the medical care. That's usually handled by the residents, be the resident's family or an organization.
Right.
However, because often the most waking hours that people are being observed is at day activities, day program, it is essential that day program staff who work directly with have some input and to be able to relate changes and be specific about those changes. So that's why all of this information that Dr. Ezralu and Catherine Pierce have provided is just really essential for you to understand. I'd also like to give another example of a secondary condition or high risk. People with Down syndrome start out with a very high rate of hearing impairment at birth, genital hearing impairment. By the age of 80, 40, in the general population, you're seeing a higher rate and increase, especially in men in the general population. But we think of people with Down syndrome as aging into their risk factors earlier. So essentially, a person with Down syndrome by the age of 40 would be similar to a person in the general population at the age of 60, who at that point in time in the general population, 1 in 4 people have a significant hearing impairment. So for people with Down syndrome, they are very likely to age in their 40s to that same rate that you see in the general population. So that goes to your question. Yes, it can be a secondary condition, and that's why differential diagnosis is so essential, that ruling out what may be causing before
Yeah.
assuming dementia.
And I want to circle back to something about day program and its role in terms of the overall support for the person. So, you know, you're going to have a team at day program, and you're going to have the person has their interdisciplinary team if they are linked to services in their given state. So if a day program you are observing changes, you certainly want to report and input that and know how the person's team, their DD team, is structured. So you have a mechanism. They usually have an annual meeting in which they're reviewing. So it could be very important. If not asked, at least you can volunteer that we have gathered this information. The other thing, and Janet, I see you, is that if there are special supports that in their home have been developed, that would be important to think about. How does that translate, or does it translate into their day programming? So this kind of reciprocal and collaborative support of the individual who is both in day programming as well as in whatever their DD services might be. So Janet, you have your hand up and you've been patient.
Yep, and I allow you to talk, so please unmute yourself. Go ahead, Janet.
Hello, I didn't even realize that my hand was up.
Oh.
But I'm sorry if I was unmuted for a while there. I do have a comment though, because it's something that we ran into recently, and that is that the tool is a great tool, and I support the use of it. I just want to comment that when you're ruling out the other things that could be causing the issue that you're seeing, and as you're trying to figure out whether or not it's dementia, I think it's important that once you rule dementia out because you found something that was awry, that you don't stop looking there. If you start seeing symptoms again that you think might be dementia, again, it's important to rule out other possible things. We've just run into that with my daughter, and we were kind of thinking that, well, we should be watching for this and that, because that would be a sign that maybe the dementia is coming through. But then we found out that it was another autoimmune disease. So she has 3 now, and I'm wondering how many she's going to get. But it's really important to not assume, just because you ruled it out the first time, that the next time you see symptoms, it may still not be dementia.
Right. It may still not be dementia, and it's a communication tool. So, to use this, it's not the only communication tool that there is, but it's a communication tool that we're talking about today. And so you can continue giving this every 6 months or 8 months or a year, what makes sense for the individual. And that's kind of, and you keep on looking, you keep on understanding. Again, we have complex individuals whom we serve and that we support. And so there can be multiple things going on and things shift.
Yeah. There's one more quick question I'll answer. If there is someone with IDD, but you don't know the diagnosis, what's the best way to figure out the individual's diagnosis to be able to determine if dementia is the condition is worsening, or if the disability is worsening, or it is dementia? You should always be, depending, I'm not sure what state you're in, Victoria, wherever, I'm sorry. Whatever state it is, you should be working with your local IDD organization, because they can help you with the diagnosis. In fact, for eligibility for funding and services, it is essential they receive a formal diagnosis. So if someone comes to one of your day programs you think may have IDD, this is a great time to start your networking, working together with the IDD experts in your area, because they can help you. There are people on staff who can do diagnoses.
That's right. They do intake, and there's a whole process of determining eligibility on the basis of that. And check the website. If you're in Michigan, then, I'm sure the state has a website for its DD services and may have community services offices that are local to where the day program is
Yes, right.
situated. Yeah.
And Lucy, I know you're on your way to another meeting and we're probably 1 minute over. Thank you so much. It's always a joy to be doing this with you. So thank you.
Same here. Same here. It's a pleasure. And thank you all for your patience with things as I kind of navigated on and off, mute, unmute.
You did great.
Great. Thank you.
You did great. Phyllis, do you want to end with announcement of the coming up, or do you want me to end it?
I'd like you to announce the coming up because the next one is Dr. Kathleen Bishop, who's,
Yes. Yeah.
presenting. So could
I'm
you,
so thrilled to have Catherine Piers and Dr. Lucy Azralu have done these sessions before, because it's really grounded me in what material. And I'm going to continue to build on the EDSD in looking at environmental, sensory impairments and processing issues. And then looking at how we can help design day program environments to be conducive to function and safety. And so it's called Dementia Capable Care and Physical Sensory Environment as part of assessment and care. I'm looking forward to doing it. It's December 12th, 12 to, we're going to hold it to 1:15 so we can do the post-test each time. And so it will be that time for those of you on the West Coast. On the East Coast, it'll be 3 to 4:15. So we're thrilled to be with you. I'm going to put the polling questions up. Phyllis, anything you'd like to add to that?
no, just a thank you for your attendance today, and we hope to see you back in December.
Thank you. And I've just put the post-test up, so hopefully most or all of you will stay on to answer the post-test. I will keep it up for a few minutes longer.
Kathy?
Yes, I'm having problems. I have it on my screen. Are you seeing it on yours at all?
No.
Okay, I'm going to shut it down and start again. And I apologize to everybody. I was so thrilled that I hadn't made any big mistakes today, and now I seem to. It won't allow me to launch. I think Catherine is off. I hope what we will do is send the post-test out, if that's okay, since something I've done is has caused a problem.